Hello everyone. Welcome to today's phlebotomy webinar on pre-analytical variables. This is Heidi Zunker, an Education Program Manager for Mayo Clinic Laboratories. Our presenter today is Dr. Brad Karen. Dr. Karen holds academic rank of Professor of Laboratory Medicine and Pathology. He has served in numerous leadership positions, including his current roles as Program Director of the Anatomic and Clinical Pathology Residency and Associate Dean for Academic Affairs in the Mayo Clinic School of Health Sciences. He was recently named the new chair of the Division of Clinical Core Laboratory Services at Mayo Clinic in Rochester, Minnesota. Just a couple of things to remind everyone before we begin today. There will be a question and answer session at the end of the program. You can submit questions online via the chat function, or following the presentation, phone lines can be unmuted to ask a question. Today's program is being recorded and will be posted to our website in a few weeks. I'll now turn the phone over to Dr. Karen.
Well, thank you, Heidi, and welcome everyone. I do remember a little over a year ago now, probably, when I agreed to give a webinar on pre-analytical variables, and starting to question my judgment of taking that on as such a broad, huge topic. So we are going to narrow this focus substantially to some aspects of this in the talk. But first, again, no disclosures for this talk relevant, and I won't be talking about off-label usage of medications or devices. So what we're really going to focus on are pre-analytical variables that are most commonly associated with unacceptable blood specimens in the hospital inpatient environment. We're going to talk about defining strategies to reduce the number and rate of unacceptable blood specimens in this context. And then we're also going to estimate the amount of error caused by specimen contamination with different types of intravenous fluids or solutions. So if we start out thinking about this idea of pre-analytical variables, usually you read and think about this really from the concept of pre-analytical errors. Laboratory errors can either be pre-analytical, those processes that happen in between the time an order is placed and the specimen is placed on an instrument or a measuring device. Analytical errors are those measurement errors in the actual analytical performance of a laboratory test, and post-analytical are recording, reporting, interpretation errors that happen after the measurement. We know that the majority of laboratory errors occur in the pre-analytical phases, and depending on the literature, somewhere between 50 and 70% of all errors are pre-analytical. They happen before the specimen is tested in the testing laboratory. And so if I had defined this subject as pre-analytical errors instead of pre-analytical variables, it would be even just as broad or even broader. And so you can see here a partial list of the major pre-analytical errors we think about. And I approach this really not from the standpoint of pre-analytical errors like putting the wrong ID on the tube, but from an idea of pre-analytical variables of variation. That is, what are the sources of variation in the quality, content, concentration of substance in a blood tube for common chemical, hematological, and coagulation tests? So we're not going to be talking about errors in genetic testing or newborn screening. So we're talking about sources of variation in common chemical, hematologic, and coagulation testing. And the errors that are the sources of variation that occur during the blood draw transport process, so pre-analytical, not analytical. Only when these sources of variability produce enough variation to impact the interpretation of the test do they then become a pre-analytical error. And so again, we're going to focus, because this is a huge, broad topic that we could talk for 3 days instead of 45 minutes, we're really going to focus on high-volume testing for hospital patients in this talk. So to get my hands around it, I said, well, okay, what are the big ones here at Mayo? And we track pre-analytical, well, we track the rate and causes of unacceptable specimens received in our core lab. And we do this across the board. We do it for outpatients as a whole, inpatients as a whole, ED and NICU. We both have separate monitors. Our most robust monitor, and I'm going to show you several years worth of data later on, is for our ED practice here at Mayo. So this is 5 months, January through June of 2019. The causes of unacceptable specimens received in our core and stat laboratories. And you can see that hemolysis is the biggie, and this shouldn't be a shock to most or all of you. And here you can see the numbers for our ED practice. 70% of our unacceptable specimens received in a core or stat lab were unacceptable because they were hemolyzed. So we're going to talk a lot about hemolysis today, so hopefully that's of great interest to you because that's going to be a big part of the presentation. Clotted is number 2, and as I'll be talking about, we haven't found great solutions for clotted. They're not as common, but we have found good interventions we can do around clotted CBC and coag specimens. Contamination is suspected, and that's in the line draws, and we'll be talking a fair amount about contamination as well because that's our number 3. Sample not received, and there's not enough blood in the tube, quantity not sufficient. Our 4 and 5, we're not going to talk about them today, just for awareness. They're 4 and 5, but we're really going to focus on our big 3 ED inpatient causes of unacceptable specimens and go into detail about the sources of variation that lead to those preanalytical errors that cause us to reject the specimen and often recollect it. So hemolysis is number 1. It's the number 1 preanalytical variable that we worry about because in our environment, and I think this is true in many other literature sources, 60 to 70% of unacceptable specimens in a core lab environment are unacceptable because they're hemolyzed. So hemolysis, first we need to understand, well, what you probably all have heard the term. What does it mean? Well, it's the presence of free hemoglobin in a serum or plasma sample beyond the amount that can be tolerated to do the testing that's being requested. So how much free hemoglobin can we tolerate, and how much is normal? That's going to be some of what I go through today. What's the usual amount of free hemoglobin? How much can we tolerate? In terms of how much can we tolerate, when do we say a specimen is hemolyzed and therefore unacceptable for testing? Well, it depends on the test. Generally, every test done in the core lab, and this is mostly for chemical analysis, so the chemical analytes, will have a limit usually defined by the manufacturer or by the laboratory, or perhaps both defined by the manufacturer, verified by the lab. It depends on analyte. There's generally 2 types of interference we think about from hemolysis, analytic and biologic. In the lab, that becomes important. Biologic interference, biologic interference means that the substance, this is potassium, LDH, AST, is highly concentrated in cells. So once we break those cells, and the free hemoglobin is a sign of the number of red cells that have broken, we really can't fix that. We have to get another specimen or not report those analytes. Analytic interference simply means the hemoglobin present interfered with the test itself, usually an optical test. Sometimes we can fix those in the lab by dilutions and other strategies. So in the lab, we need to know if it's an analytic or biologic interference. This also depends on the lab. We're going to talk about literature on rates of hemolysis and talk about our experience at Mayo. In general, most labs will accept the manufacturer-defined specifications for the amount of free hemoglobin that can be tolerated before you have an analytic or biologic interference. However, some labs will make their own guidelines based on their own testing, and some labs have different takes. So some are very strict and reject all specimens over the manufacturer's guideline for free hemoglobin. Some would have sort of an indeterminate range where if it's a little too high but not too much, they might release that result with a comment, and therefore it doesn't become an unacceptable specimen. So a lot of what we're talking about, hemolysis rates, isn't really apples to apples because the labs all have their own way of handling hemolyzed specimens. So with all of that and those caveats, how much hemoglobin is too much, how much free hemoglobin is too much, and we usually measure this on automated chemistry equipment. Nowadays has an H-index, an optical measure of free hemoglobin, and the H-index, at least on the Roche technologies, roughly correlates to the milligrams per deciliter of free hemoglobin. And so for most of the most sensitive tests to hemolysis start to become unacceptable when they're somewhere between 50 and 150 milligrams per deciliter of free hemoglobin. So in general, hemolyzed would have a free hemoglobin above that. Now again, it will be test specific, so a lot of tests are very generous tolerance. So the frequent flyers, potassium, AST, direct bilirubin, if they're ordered a lot, we're going to be able to tolerate less free hemoglobin because they're the most stringent and tolerate only somewhere in the range of 50 to 150 milligrams per deciliter of free hemoglobin before we say those specimens are unacceptable for those 3 tests. So we know hemolysis is the #1 reason for redraws, and the #1 reason for hemolysis is drawn from an IV start or a central line. And so we have, I'm going to show you more data, but in the ED practice specifically, where you tend to do a lot of blood draws during an IV start, there have been a number of studies, and I give you 2 references to studies done, that show that the hemolysis rate in samples that are drawn during the placement of intravenous catheter, most of these studies done in the ED setting, that the rate is 2 to 5 times higher than venipuncture. So whatever our hemolysis rate is on venipuncture, if we're going to rely on IV start blood draws, we know the hemolysis rate is going to go up 2 to 5 times. And you give some references, the absolute numbers will differ in terms of venipuncture hemolysis rates being very low, less than 1%, over 5% for IV starts in one study, versus 5% for venipuncture, twice as high at 10% for IV starts in another study. So the absolute rates differ, but the literature is consistent. Hemolysis rates 2 to 5 times higher in IV start draws as opposed to venipunctures, and that's a major factor in hemolysis in the ED setting, where a lot of blood draws are done at the time an intravenous catheter is being placed. So we know, and I've just told you that for the most sensitive chemical tests, we can't tolerate more than somewhere between 50 and 150 mg per deciliter of free hemoglobin. But what is the average amount of free hemoglobin, or the average H index, in a serum or plasma specimen drawn by venipuncture, in a line draw, in a capillary puncture? This is good, hopefully useful information for you to know, because again, we're talking about variation. There's always some free hemoglobin you're going to break some cells. There'll be some free hemoglobin in specimens. And so one study here at Mayo Clinic, we had 88 ED samples. We measured H index for samples, or serum samples that were tubed a mile in our 1 mile long pneumatic tube, so that factors in, versus plasma samples that were sent to the stat lab but had a different centrifugation, a faster, harsher centrifugation. And we found in those 2 conditions, which are probably testing the routine collection and processing about as much as you can, tubing specimens a mile or stat centrifuging plasma samples, that the average H index was around 20 for both serum and plasma. So on average, so our typical blood draw, you're going to have around 20 mg per deciliter free hemoglobin, at least in our practice, and when it gets about 50 to 150, that's where we say it's unacceptable. That gives you a sense of the amount of additional hemoglobin or variation that causes unacceptable specimens. We did a study looking at venipunctures versus line draws on pediatric outpatients here at Mayo Clinic, and again, we saw, H index of 12 by venipuncture, 15 by line draw. So this is a data set that shows you for a routine venipuncture, for a good line draw, or a venipuncture even on a child, we can typically get an average free hemoglobins in the under 20 range and have a little bit of buffer or margin until we get to 50, 100, where we reject samples. Capillary punctures, on the other hand, are quite different, and data from our Mayo Clinic and others suggest that the average H index among infants on a capillary puncture is already above 200. So we know there's going to be problems measuring some of the basic chemical analytes on capillary blood draws. Getting ready for this talk and preparing it, the big question is, what's the average free hemoglobin in an IV start draw? And there were just a couple of very small studies that had small data sets, and I really wasn't even comfortable drawing that conclusion. So I would like to know that. Maybe one of you out there has the answer, but I could not find the answer to the obvious question. We know IV start draws will be 2 to 5 times more likely to be hemolyzed, but what do we expect to be the average hemoglobin on an IV start blood draw? I couldn't find a good data set to answer that question. We can turn the question around, though. Instead of saying, well, what's the average free hemoglobin we expect in an IV start draw, what's the best we can do? So given that labs do vary in what they call reject for hemolysis, what a study shows the lowest achievable rate for hemolyzed samples when you're using IV draws from an ED setting. And our own experience and the literature suggests you can't do much better than having 5 to 8% of all IV start draws hemolyzed. And so that's, of course, much less, as we'll see, than the overall venipuncture rates where you can get down to 1 or 2%. And then we know that the NICU is also a challenging environment for collecting specimens and not having to redraw. And so the second question, what's the lowest rate of hemolyzed samples from ED and NICU when we optimize sample collection conditions? So we do fewer than 10% IV start blood draws in the ED, and we do multiple interventions, I'll tell you about in a minute, to reduce hemolysis rate from the NICU. And so we have data in both environments, ED and NICU, that shows that we've been able to achieve over time about a 2 to 3% hemolysis rate. So if you're doing all IV start draws, literature suggests the best you can do is 5 to 8% of all your samples will be hemolyzed. If you minimize IV start draws in the ED, if you do some of the interventions I'll talk about in the NICU, you can get that down to 2 to 3% for all specimens hemolyzed, but it's still going to be higher than routine venipunctures or even adult routine line draws. IV starts are going to be more problematic than line draws, central line draws. And again, our data suggests that in the NICU we did interventions and improved training that reduced hemolysis rates. There's no evidence that suggests better training can get your IV start draw hemolysis rate down below that 5 to 8%. So I don't believe myself you can train that away. If you're going to draw blood routinely from IV start draws, you have to live with 5 to 8% of hemolyzed samples, much higher than other draw conditions. So we will focus on NICU just a little bit. NICU is another problematic area like ED for hemolysis. If you look at the literature, people report hemolysis rates from NICU anywhere between 2 and 10%. Venipuncture is often not a good option. It's in these patients. They have catheters, indwelling lines, because they are difficult to access. And our studies and others showed the factors associated with hemolysis rates for chemical testing from the NICU population are using serum instead of plasma, plasma being the preferred specimen in infants, administration of medications, especially lipid emulsion, pneumatic tube transport, which we often can't do anything about, but is a factor, and the probably most important one, the training and education of the nursing staff on slowly withdrawing from arterial and venous catheters, so the rate of withdrawal from the lines. So how do we know these are important variables? Well, this is a study we did at Mayo where we looked at all these variables. We were able to reduce our NICU hemolysis rates from 6 to 4% by making sure that by trying to avoid drawing our AM draws, our routine draws, during a time when lipid emulsion and nutritional support were being given, so lipid cycling, so we pause that nutritional support around the time we expect to draw blood samples. Retraining nurses and then retraining nurses to slowly withdraw blood from arterial and venous catheters. That got us down to about 4% at the time of that study I have the reference for. Since that time, we've switched from a mixture of serum and plasma to all plasma testing. And for the most problematic infants, the low birth weight infants, where we often had multiple hemolyzed specimens, we switched to bedside point of care support for those infants. Those two additional measures to the ones we published a few years ago have allowed us to stay at a 2 to 3% hemolysis rate in the NICU, which I just mentioned on the last slide. And then key factors I mentioned are the lipid emulsion cycling, not drawing routine blood draws, while nutritional support is going on, nursing education, and the use of plasma instead of serum samples. So those are some of the major interventions we've done to reduce our hemolysis rate in the ED and NICU in particular. There are others that I think some of you in your questions wanted to hear about. Butterflies come up, the never-ending saga of why does our staff use so many butterflies. Drawing with small gauge butterfly needles there's a good amount of literature that shows historically this increases hemolysis rate. It's a very controversial area right now. One of the vendors has reconfigured their butterfly needles with the goal of minimizing hemolysis. So the butterfly needle has a thinner wall with no change in the overall size. So the bore size, the size of the blood, the size of the tube of the needle the blood is running through, which is really the key factor for hemolysis, in a current 25 gauge device is the same of what used to be a 23 gauge butterfly. And they've also changed the beveling to decrease pain, and they've showed that the fill rates of the tube, which would also delay filling, increase hemolysis, for a 25 gauge are about as good as what used to happen for a 23. And so our own data and some of the literature suggests that butterfly needles, 23, 25 gauge butterflies, I'm going to show you some data in a minute, are no longer as big a concern about causing hemolysis. And in fact, the CLSI guidelines, which used to state that use of butterflies would increase hemolysis, has now changed their verbiage on this and says the use of some 25 gauge needles increases the risk of hemolysis, but it isn't clear right now how universal that statement is. And so here's some data we looked at a pediatric study. Here it gives you with 21, 23, and 25 gauge butterfly needles, and you can see the number of samples relatively small, 56, 18, 26. But you look at the mean hemolysis index, it actually went up from 23 to 25, but then back down again at 25. So if you look at 25, the mean amount of free hemoglobin in a 25 gauge was the same as a 21 gauge. So again, it's really, we're at a point where with newer technology, we don't know how big a factor use of a 23 or 25 gauge butterfly is. And again, you have to realize that this is a pediatric study, so they were done in the appropriate infant. So we're using a 25 gauge butterfly when there's tiny, with an infant with very small veins. So we're still matching vein size to needle size. If you use a 25 gauge on an adult, you're probably still going to increase hemolysis. Another interesting variable, and I really hadn't explored this much before getting ready for this talk, is the use of smaller volume blood tubes and low vacuum blood tubes. We know IV starts and line draws have more hemolyzed specimens because the rate of blood withdrawal is not governed by the vacuum in the tube. But if tubes have a lot of vacuum, you could imagine similar to pulling hard on a syringe and hemolyzing blood, that the tube vacuum being too high would cause hemolysis, at least in some patients and under some conditions. So here's a study that found that switching from a 6 milliliter lithium plasma tube to a 2 milliliter lithium heparin, so whole blood, but eventually make plasma tube, that had a reduced amount of vacuum, had a significant effect on the hemolysis rates in the ED, changing from about 12% to 3%. The study used IV starts for all blood draws throughout the study, so you keep that in mind. And not all studies of low vacuum tubes have shown the same effect. So it's sort of an interesting, intriguing, like butterflies, an unknown, controversial area. Do low vacuum tubes really help with hemolysis rates in the context of ED or ICU or patients that are difficult to draw? And it isn't clear right now. I think underfilling the tubes has clearly been shown to be causing more hemolysis. So there's some logic, at least to smaller volume tubes, if you fill them completely, it's going to be better than having a half-filled 5 or 6 mil serum or plasma tube. So these are really going to, I'm at the end of hemolysis here, but we could go on just about hemolysis probably for another hour. There are transportation conditions. We've tried trials of padded tube carriers, mixed data, not convinced. Again, another controversial area, like low vacuum tubes and butterflies. Maybe the padded carriers for pneumatic tubes help. Time to separate cells, and I think there was a question about this. Yes, you should separate serum and plasma within 2 hours max, preferably a little shorter time. Use of gel tubes is going to help within the lab. Centrifugation conditions I mentioned briefly or alluded to really. Stat centrifugation versus routine, that's going to have an impact. And then a lot of factors during the blood draw, tourniquet time, needle diameter, probing, not letting the alcohol dry is going to cause hemolysis as well. Underfilling or shaking tubes instead of filling and inverting them, those are all going to be variables leading to hemolysis. So here's this monster slide showing 5 years worth of unacceptable specimen redraw rate from the ED going through various periods of time. And you can see historically we ran in the 4 to 6% of ED samples were hemolyzed. And the lines here, A through L, reflect different interventions that we've tried, and I'm not going to go through them all. I'll give you a sort of a snapshot of some of the things, and they're really going to capture many of the variables I talked about. So during period A, we started working with nursing in the ED to say, hey, let's do less IV start blood collections. Prior to period A, when we were running 5 to 6% redraws, about half of all draws in the ED were during IV start, about half by venipuncture. During period B, you can see trending down from A to B. B was the second pilot working with nursing and ED leadership to discourage IV start draws. So A and B, the only intervention we did is say fewer IV start draws, more venipuncture. You can see it was very effective. During period C, towards the end of that and into D, you can see our hemolysis or redraw rate went up. Our hemolysis rate went up. And that was actually implementation of a new instrument in the stat lab that offered an optical H index as opposed to somebody looking for visual assessment of hemolysis. And so most chemistry analyzers now have this, but you can see when you have an automated system to measure free hemoglobin, you detect it more often. And so we had rates shoot back up when we started using automated H indices as opposed to visual assessment in both the core and stat laboratory. During period E, we had things starting to come down again. And then in the end of period E to F, it came down again by adjusting the rules for the stat lab H indices. So we shot up when we started using H indices automated in the stat lab. Then because the stat lab served the ED, we softened some of those rules. We're able to get the rates back down a bit into the 3% range or so. During periods E and F, you see the rates went back up. Well, what happened there? During period E particularly, but also into F, tests that had been done in another lab were moved into the core lab. And those tests, it was actually acetaminophen was one of them, also had a lower tolerance for hemolysis. So when we move tests into the core lab and they become hemolysis sensitive, then that will affect rates went up. So obviously our phlebotomy staff didn't do anything wrong, and they were probably wondering, why are we getting more redraws? But change of the testing menu shifted the hemolysis rate up during periods E and F. Things went fairly stable then. You can see through G and H there were various pilots being done. But our hemolysis rates was fairly stable. You can see at the end of period H into period I, there was a dramatic drop again from 3% down to about 2% hemolysis rates, and we're just above that since then, with one exception I'll talk about. With all the work we've done, it's a bit frustrating. We actually don't know what happened. That's why there's a question mark on the slide. We really don't know we changed a whole lot of things. We don't know which one of those was responsible for about a 1% drop in hemolysis rates. During period J, we saw another spike that correlated with the implementation of a new EMR system in our practice. And again, that's an interesting study in itself. It shouldn't have changed anything, and we've sort of written it off as just everybody was stressed trying to figure out how to use a new EMR, and therefore not taking the care during blood collection. But you can see that with further training, that came down during periods K and L, and we've been stabilized at about a 2.5% EG redraw rate since then. So that's a lot of data. It's 5 years worth of data and a summary of all the things that might go into affecting how many hemolyzed specimens in the ED or hospital environment. Okay, so we've reached the end of hemolysis finally. These other topics are a bit shorter. Hemolysis is number one. It's our biggie. So clotted samples, it's number two. I show you that. So CBC specimens and coagulation specimens. Our CBC specimens are collected in EDTA tubes, coag, and citrated plasma. If those clot before testing, they're unacceptable. Most labs have a system, usually visual, to assess for clots before they test. We know that clotting of CBC and coag specimens tends to happen on larger blood orders. We know it tends to happen probably most often on infants and children. And so we've looked at training, and we've actually experimented with a two-tech pediatric CBC collection, so one to draw and one to make sure the tubes get mixed quickly, but we really couldn't staff or support that. And so we don't have a magic bullet. Again, we do observations on especially infant blood draws, and we have to just keep stressing the need to get blood into the EDTA tube and that tube mixed quickly and follow order of draw, and that's really the only thing we found to help. And I guess, again, if any of you have a magic bullet for clotted CBC specimens in particular, let us know. So we'll move on to line draws, and this is getting into number 3, sample contamination. Sample contamination is the number 3 cause of unacceptable specimens in the hospital environment. Really doesn't apply that much to outpatients. Not many outpatients have intravenous fluids running through a catheter or line of some sort. But we know there's a lot of issues with line draws. We can cause hemolysis by taking the blood out of the line too quickly with a syringe, usually. We can dilute blood with intravenous solution, so the concentration of everything we measure is affected. We can get the drug we're trying to measure, whether that's a therapeutic drug or heparin, an anticoagulant, the drug we're trying to measure either directly or its effect, so a 10A or a PTT for heparin monitoring. We can get the drug in the specimen because it was in the line, and that's maybe one of the most dangerous types of interferences or problems with line draws. And so all of these things are problems with line draws. So if we have so many problems with line draws, why do we do so many in the hospital? Well, patient comfort and convenience, nurses trying to protect patients, no, don't stick them. Burden on dedicated phlebotomy staff. In most practices, nurses draw from lines. In many practices, a lab person will do a venipuncture. More timely, so we can, if they're doing medication monitoring, it's going to be more timely to access the line rather than wait for someone trained in venipuncture to get there. And these patients have difficult venous access. They're sick, they're in the ICU or ED. Once you obtain venous access with a catheter, many times the intention is to use that to draw blood samples because these patients are hard to stick. So what are the CLSI guidelines? Tell us about the best practices around line draws. Well, they say, again, discontinue IV fluids for 2 minutes, flush the line with saline, and then discard usually about 2 times the dead volume of the lines. The dead volume is the distance between the end of the catheter and the patient and the port where you're drawing the sample. 2 times the dead volume for non-coagulation tests, up to 6 times the dead volume for coag testing. And the guidelines say that usually, if you don't know what that dead volume is, that 5 milliliters is usually enough. And it says don't draw drug levels from the same line you're giving the line. So that's the example. If you're infusing heparin through a line and you do a test to monitor heparin's effect through a PT or 10A, obviously you have a high risk for contamination. Our practice here, we really are very similar to guidelines. We discontinue IV solutions for 2 minutes whenever possible. Sometimes that's not possible, and then our phlebotomist will note that for the lab when they're evaluating whether it could be contaminated, to know that it was not possible to discontinue IV solutions in a given patient. We do a 10 cc flush, a little larger, and we have a standard 5 cc discard according to CLSI guidelines. There are some caveats through experience we've learned. If dextrose or TPN is being given to the patient, we're going to waste more, at least 20 cc's, at least 10 cc's, and 20 is preferred if we're measuring glucose and giving glucose at the same time. We prefer not to do a line draw, but if they absolutely have to measure glucose and glucose is being given and the line's the only option, we'll discard a large amount of blood. 10 cc's is our minimum for all coag tests, so that's a bit different through experience here. We've decided, and this is according to guidelines, we really want to avoid drawing a drug level through the same line used to give that drug. We can do line draws with either Vacutainer or syringe. We really prefer to use a Vacutainer if the adapter is available and the line is drawing freely. So we know there are a number of problems associated with line draws. We can get hemolyzed specimens. That's number one. But we can also get contamination. And contamination, most often in a line draw, is one of these problems I've listed here. Falsely elevated glucose, falsely elevated or decreased potassium, falsely increased magnesium, phosphorus, or calcium, decreased creatinine, decreased cell counts, or decreased sodium are the most common pre-analytic problems or errors due to line draws. So our experience with line draws is PICC lines are overrepresented among contaminant specimens, and this is a lot mainly because now there are more dual lumen PICC lines, but in the past you only had one lumen, so you really had to be giving some solution through the same lumen, the same device. Basically, you were taking the blood, whereas central venous catheters have multiple lumens often. We know that draws from patients on total parenteral nutrition, so nutritional support intravenously, are problematic, and I think we get a lot of questions about TPN and lipid emulsion, TPN in particular, so I'm going to talk about that and why it causes problems. So we know that if we can avoid line draws in patients getting TPN, we're going to be better off. And we know that patients getting intravenous magnesium or calcium or phosphate replacement are problematic. So we try to get the right timing between the giving of those compounds intravenously and the lab measurements. So many years ago, over 10 years ago now, we did a study in both of our hospitals, St. Mary's and Methodist, where we asked if we knew that we were pausing the infusion and doing the right waste, would there be contamination in line draws? And so that was the basic question we wanted to ask. And so we sent people out to observe 541 line draws at Methodist Hospital. They observed that the infusions were paused or there was nothing being infused. Infusions were paused 2 minutes or there was nothing being infused when the draw was done. And we had no contaminated specimens out of 500 line draws. At St. Mary's, we had about 150 line draws. Again, same thing. Infusions were paused or there were no infusions. And all of them had a proper discard. And again, we saw no contaminated specimens. So we think that you can avoid contamination if you do the 2-minute pause, have the proper discard, avoid TPN or patients getting a calcium or magnesium or phosphorus intravenous infusion. If you do a few simple things like that, you can avoid contamination, but obviously that's easier said than done. Those are all things beyond the lab's control, so we just try to make people aware of that and do the best we can to have the IV pause, the right discard, avoid patients getting TPN or calcium, magnesium, or phosphorus intravenously at the time of the blood draw. So again, here's our approach to intravenous line draws. Our line draws and contamination. We discontinue all IV solutions for 2 minutes whenever we can. That's a nursing decision to make. We discard 5 cc's. If we're giving TPN or dextrose or, again, a drug, we're not going to use that same lumen for the collection. And we ask if the discard comes easy in the syringe, use a Vacutainer or adapter for the draw rather than a syringe for the actual blood draw. So total parenteral nutrition, again, that's overrepresented in our contamination. And TPN is actually nutritional support given intravenously and is compounded by a pharmacist individually for each individual patient. So we have found it hard to sort of look up online and say what's in TPN that's causing all these weird results. So years ago we actually went to the pharmacist and says, tell us what's in this bag of TPN, and because we had found that patient getting that solution had funny results. And so this is presented for your knowledge. This is not going to be universal, but this particular TPN was compounded for a patient, had astronomically high glucose, 15,000 milligrams per deciliter glucose, very low sodium, so again, you wouldn't expect TPN to falsely increase sodium, it should decrease it, but very high potassium. You can see normal potassium where you have to 4 or 5, 16 millimolar potassium, and then this astronomical glucose, extremely high calcium. So therefore, what are most likely to be signs of contamination from TPN solution in a blood draw? Glucose, potassium, and calcium will be the most likely abnormally elevated, and often so far elevated you can't believe they're real. from a TPN blood draw. And again, we need to remember that there's a lot of other stuff in TPN that could affect tests we don't do as commonly, like insulin or vitamins. All right, the last thing I'm going to touch on before we take a few questions is another area of contamination, but this one not from line draws. This one, contamination due to order of draw, which is actually another interesting controversial subject. So the European Federation for Clinical Chemistry on Preanalytical Phases Working Group drew up an opinion paper, and it just documents here all the problems that can be caused by not following the right order of draw. And so in this opinion paper, they looked at all the literature, the knowledge that existed, and they postulated 3 potential mechanisms that would allow anticoagulants, so usually potassium EDTA from an EDTA tube or sodium citrate from a citrated tube, to get into a serum or plasma specimen and cause this contamination, usually potassium, also magnesium, calcium, zinc we'll talk about. So there's direct transfer, and so that's you draw an EDTA tube and you pour it in the serum tube. And that's obviously a bad practice, so we don't want to do that. It's really not an order of draw problem, that's just bad practice. There's backflow during a closed-loop vacutainer collection. So if you have a vacutainer adapter and you snap on an EDTA tube, some of that EDTA could stick to that vacutainer adapter and then backflow into the tube. And the question is, during routine outpatient draws using a vacutainer collection system, does that really happen? And I don't want to spoil the ending, but the answer is probably not. And then there's contamination through syringe needle transfer when you draw in a syringe. And the evidence suggests this still happens, although the rate seems to vary widely in different places. So I'm going to go through a few studies. Here's one in 2012 looking at healthy outpatient volunteers. They drew a serum, then an EDTA, then a serum. They measured all the things that would be affected by potassium EDTA. So potassium, calcium, magnesium, zinc. Elk phos is an enzyme, so if you bound up the calcium, elk phos is 0. And they really found no difference between the first and third tube, so they concluded that there really, in these patients, there was not backflow contamination of EDTA during a vacutainer draw. Another one of the larger 57 outpatients, they had both serum citrate serum and serum EDTA serum. And again, they found no backflow contamination of either EDTA or citrate getting into the second serum tube during a routine venipuncture with a vacutainer. Yet another one, 100 patients, outpatient anticoagulation clinic. Again, different order, citrate, heparin, citrate, serum, citrate, EDTA, citrate. And they were looking for carryover of one anticoagulant into another tube. And basically, they didn't find any difference in the PTT, so they found that there was no carryover of citrate into different tubes. So here are 3 studies that suggest that backflow contamination during a vacutainer blood draw is either doesn't happen or is very uncommon. What about inpatient venipunctures? So here's a study, again, some of the same investigators from the outpatient studies that looked at 1 month sampling of all samples in the laboratory that had a high potassium. Potassium's over 6. So potassiums over 6 happen in sick patients, but they're not that common, so they studied how many of these are because there's potassium EDTA from an EDTA tube in the serum sample. And what they found among 117 samples that had potassium over 6, about 25% of them had some detectable EDTA. And since we never give EDTA in a medication or anything, the assumption was it got there because there was carryover from an EDTA tube into a serum or plasma tube. Here's another study from multiple hospitals in the UK, and they studied all specimens with high potassium over 6, and you can see that anywhere between 1 and 7% of specimens with high potassium had EDTA detected. So again, they suggested that EDTA contamination from order of draw in a syringe collection was Not common because you're only selecting high potassiums. Those are not common themselves, but it does happen somewhat routinely. So conclusions on order of draw. The evidence suggests that EDTA, potassium EDTA contamination doesn't occur during closed draws with a vacuum system, so there's no evidence that this backflow contamination that you get if you draw an EDTA tube by vacuum first. There doesn't seem to be evidence that EDTA, potassium EDTA, would stick to the vacuum after and get into a serum or plasma specimen that's collected next. So you could say that for a vacuum routine collection, order of draw doesn't seem to make much difference. However, there is evidence in at least 5 hospitals in the UK that potassium EDTA contamination is seen anywhere between 2 and 15 samples with abnormal potassium or calcium, magnesium, or zinc. So again, when you select for somewhat unusual findings, very high potassium, very low calcium, magnesium, or zinc, you find that around anywhere from 1 to 5% of them in most studies are caused by EDTA contamination from EDTA tube. So it does seem to happen. And our own practice and experience here at Mayo suggests the same thing. We do see rarely that we see samples that have very high potassium that are repeated with normal potassium within an hour or 2 later, and we measure the calcium or magnesium and zinc and it's very low. We assume that this was contamination with potassium EDTA from order of draw, but it isn't clear why it happens with syringe draws and doesn't appear to happen with vacuum draws. All right, so we've gotten through pre-analytical variables. It was a big subject, but again, I narrowed it to the common causes of unacceptable specimens in inpatients, hospital patients. So we know hemolysis is the #1 pre-analytical variable, and this will be true for inpatients and outpatients, but my talk focused on inpatients. When we know that the most problematic pre-analytical variable in terms of introducing too much free hemoglobin is the practice of drawing blood during an IV start, usually in ED, but it could be in other areas. And I suggested that the best you can do with IV blood start draws is a 5 to 8% hemolysis rate, whereas if you can go away from those, you can get hemolysis down lower, 2-3% in our practice, and other practices suggest in problematic areas like ED and IC and NICU, 2-3% may be among the better you can do. You can get overall through the hospital certainly less than 1% hemolysis rates, but we focus on the difficult areas like ED and NICU and try to get those rates down in the 2% range. We think we're doing well. Clotting and contamination are the next most important pre-analytical variables. Contamination with IV fluids can be prevented. Again, I showed that, and again, it's not in the lab's control, but to be aware of, if you can discontinue IV solutions for 2 minutes, do a 5 cc discard at a minimum. Again, that's a kind of routine or minimum. If you're using TPN or giving dextrose, we have some exceptions, but 5 cc discard at minimum. And then if you can find some ways to deal with the heavy hitters, dextrose administration, TPN, total parenteral nutrition administration, giving heparin a drug when you're trying to measure the drug or the effects of that drug. If you can avoid those things, you can avoid a lot of the problems with contamination of specimens from collection through indwelling lines. Clotting, again, we don't have a great answer for clotting. Clotting has defied great systematic solutions like I've showed you for hemolysis, other than training and education on order of draw and appropriate inversion of EDTA and citrate tubes immediately after filling. And then I reviewed some data on this issue of potassium EDTA contamination from the incorrect order of draw. There's a lot of interesting controversy. Does the order of draw still matter? The answer appears to be yes. Incorrect order of draw is a sporadic cause of contamination when draws are done with a syringe in the inpatient hospital environment. It doesn't seem to be happening in outpatient areas where you're using a vacuum collection method. So these are the references of little stars have to these references if you'd like to read more. And I'll turn it over to Heidi to moderate some questions.
Thank you, Dr. Karen. As he just mentioned, we will be taking questions at this time. So if you'd like to ask a question through the phone line, you can press *7 to unmute your phone. And then once you've finished asking your question, you can press *6 to mute your line again. Also, you can submit a question via the chat function on the CenturyLink web application.
So I see there's a few questions submitted on the question box here. First one is, does the type of needle used during venipuncture impact hemolysis rates? Example, butterfly versus straight needle. That's a really fascinating question, and I avoided putting it in to the talk because my sense is, and most of the literature suggests, that a vacuum container collection in the ED environment will have a lower hemolysis rate than a butterfly. But there's one or two studies showing the reverse. So it's actually an interesting question. I presented a lot of data about butterflies, 21, 23, 25 gauge. And before technology helped improve these devices, it was very clear use of a 23, 25 gauge led to higher hemolysis. My sense is overall vacuum containers will be a little bit more reliable, have less hemolysis than a butterfly, but again, both the data and now with newer technology, there's more uncertainty. But on the whole, I would say the best collection is going to be a vacuum container needle collection, and then a butterfly would be second choice, and the third choice is always going to be during the IV start, and now we do that pretty infrequently in the ED. How did we get ED staff to draw cell labs separately from IV starts? Well, it wasn't easy. That's why it was a 5-year project. So ED, of course, everybody wants high-quality patient care, but the physician, and especially physician, but both physician and nursing leadership in the ED were also very acutely aware of the fact that when we have to reject a specimen and redraw, patients are sitting in the ED, and they don't like patients sitting in the ED. They get part of their major metric is how efficiently they get patients out of the ED. So I think a lot of the selling point with nursing and physician leadership in the ED was that let's try this, discourage IV start draws, use them. We do have phlebotomists in the ED to draw blood, and that helps, and certainly. But let's try discouraging IV start blood draws and doing a separate venipuncture, even if we're going to start an IV, and see if we can get the redraw hemolysis rate from 6% to 2%. And that means you're making decisions and dispensing patients, discharging or treating patients. And that was really the sell that allowed it to proceed. So the next question is if a free hemoglobin estimation is a necessary route of hemolysis, does that increase cost? And that's where I mentioned that most automated analyzers have a built-in optical H-index. So it's not a separate, in a sense, it's sort of like a separate test. There's when the sample goes on the instrument, before a test is done, light is shined through it to measure H-index. That does increase the cost of the instrument, not on a per test basis necessarily, but the instrument. But it is accepted that the best practice in automated chemistry testing is to use an automated H-index. So why flush with 10 cc's and only draw back 5? Well, the major reason is that we're sensitive to the amount of blood we're taking from patients. And actually, when we have closed-loop devices now, and many of you may have these, we could do bigger discards because we're not actually discarding, we're temporarily taking out the blood. But the reason for a large flush and a 5 cc discard is most patients are not volume sensitive, so they can handle a little more flush going through the line to clear it, but we don't want to be discarding, truly throwing away 10 cc's or 20 cc's of blood every blood draw. Now, for coag tests and for TPN patients, we'll have exceptions, but the larger flush than discard is because we don't want to be wasting that much blood from the patient. How do you calculate percent hemolysis? So again, what our metrics, and I showed you 5 years of ED data, are among all collections sent to the central clinical or core lab and the stat lab, what percent were rejected for any reason, and then among those, how many for hemolysis versus other causes. So it's really a numerator is the percent that were hemolyzed, and the denominator is all the specimens collected and sent to either the core lab or stat lab. So that would exclude, again, a blood culture or other things, but they tend not to be sensitive to hemolysis. So the tests that are sensitive to hemolysis are sent to our core lab and stat lab. How is low blood volume in the tube correlate with hemolysis? That's a great question. There's a couple of good studies out there that do show underfilling of tubes is associated with hemolysis. So when they studied it and they showed underfilled tubes had a higher hemolysis rate than properly filled tubes. Mechanism isn't entirely understood, but it's assumed, and then if you look at the review articles, literature, they'll say shaking of blood tubes causes hemolysis. You're just like drawing too fast in a syringe, it's mechanical disruption of cells. So I think how it works is that when you underfill a tube, even when you invert it properly, the tube's not filled, so the blood has farther to fall one side of the tube to the other. So essentially underfilling tubes becomes a part of shaking tubes instead of inverting them, or it's a similar concept to shaking versus inverting blood tubes. So I did not, the next question, I mentioned 1% overall inpatient rate. I didn't show that. You're right, I didn't. I focused on data from the ED and NICU. We do have monitors for inpatient rate, hemolysis rate, outpatient hemolysis rate, overall hemolysis rate. Historically, our overall inpatient, among all the blood we draw in inpatients, our hemolysis rate has been just under 1%, sometimes between 0.5% and 1%, sometimes just a little over 1%. Our outpatient hemolysis rate tends to be under 0.5%. So those are historical figures, but you're right, I did not put them in the presentation. So as a comparison, those are for comparison. So 2 to 3% is the best you can do in the really difficult areas, ED and NICU. Overall, you ought to be able to get your inpatient hemolysis rates below 1%, I think, is a good goal, and I threw it out there but didn't show our data or other references to that. Next one is interesting. I'm trying to go in order here. Is hemolysis rate measured by one analyte such as potassium or all specimens received? No, it's all specimens received. So again, potassium, AST, direct bilirubin have lower thresholds. So in our core lab, those are ordered a lot, but the hemolysis rate is out of all blood we collected and sent to a core lab or stat lab. For the tests that were ordered on that specimen, could we do it? And or did we need to recollect it? So if you were in a practice where they happen not to want potassium or AST or direct bilirubin measurements often, you might have lower hemolysis rates. If it's being ordered on every specimen, you might have higher. But it is measured as of all specimens that were collected, were we able to do the test requested regardless of whether potassium was requested. Now I think if your practice is like ours, in the ED, potassium is requested in almost every time we do a chemical analysis, so that's a common one. The last question I'll take, observation about EDTA contamination being lower when tubes are filled from bottom to top. And could that be the difference between why there's no backflow if someone's sitting in a chair versus lying on a bed? I think it's possible. I think the whole controversy on order draw was that back when we had liquid anticoagulant, conceptually it was a lot easier to get that in the tube, whereas now the anticoagulant is sprayed under the sides of the tube, lyophilized. So it could matter. I think that's a novel idea. I don't have any evidence to say yes or no, but yes, filling the tubes having the blood going to the bottom of the tube first certainly could theoretically impact carryover contamination.
Okay.
But, yeah.
Well, we are at the top of the hour here. Thank you so much, Dr. Karen. Appreciate you answering those questions. And thank you all for participating in today's phlebotomy webinar. If you do have any additional questions, please indicate them on the evaluation that will be forwarded to you shortly. Note that laboratory credit is extended for this program. Upon finalizing your evaluation, you'll have the option to claim credit and print your certificate. As a reminder, this program was recorded and will be archived on our website in a few weeks. Please visit the education website for more information on upcoming education offerings and a list of upcoming phlebotomy webinars. The next phlebotomy webinar will be on November 27th from 11 a.m. to 12 p.m. Central Time on ethical issues in phlebotomy. Thank you again for joining us today and have a great afternoon.